Yeah, good evening, everyone. Our guest speaker today, in the person of Dr. Hadi, will be speaking on clinical pearls in ophthalmic lens dispensing. Before we start, I will briefly introduce our speaker. So our speaker, Dr. Hadi, is a graduate of Imo State University, Nigeria, where he earned his Doctor of Optometry degree. And due to his passion for eye care, he served in numerous capacities, both during his undergraduate days and currently as a professional. To mention a few, he was elected as the Student Union Director of Health and President of Nigerian Optometric Students Association in Imo State University, where he played an active role in assisting Dr. Christian Duru to establish this great forum where we are currently having this webinar. And also, he went on to do his NYSC in Abia State, where he was awarded the best core member by the then state governor of Abia State for leading numerous eye care outreach programs and other community development projects. Thereafter, he was honored by the then president of Nigeria, Muhammadu Buhari, and was offered a federal scholarship up to a PhD level, in addition to a federal government job. Right. But currently, Dr. Hadi is an active member of a 9-man educational committee at the Odoben, and he currently works with Exilo. We all know Exilo is a world-leading optical brand, which makes more sense that he's speaking on a topic that is strongly related to optics. And he's truly, like I said, yes, he's currently working with Exilo, and we are truly excited to have Dr. Hadi share his passion with us today while he's speaking on the clinical pearls in ophthalmic lens dispensing. It's also worthy of note to state that he had previously delivered a scientific lecture on this particular topic during one of our NOSA conference. During one of our NOAA conference. So it's really a privilege to hear from Dr. Hadi this evening. So I will be passing the mic on to Dr. Hadi now. I believe he's currently present in the meeting. So please, Dr. Hadi, the floor is yours. Thank you very much for agreeing to do this evening.
All right. So my name is Dr. Hadi Mbadugha, and I will be presenting on clinical pearls of ophthalmic lens dispensing. So ophthalmic lens dispensing seminar comprises of multifarious topics aimed at throwing more light on some clinical procedures we wrongly or have neglected. But this evening, we'll briefly talk about the essential rules for the successful fitting of progressive lenses to your presbyopic patients. So what we are going to discuss only for today is progressive lenses. If time permits us, I have on this slide, we're going to talk about anisometropia, aniseconia, and isoconic lenses, how you can use them to, how you can order isoconic lenses from your clinic. So this module has been designed as a guide to take us through the successful fitting from first contacts to the final delivery of the progressive addition spectacle lenses. This will enlighten us about those little things we take for granted in our clinics here in Nigeria. So this content is a genuine working tool. So at the end of this seminar, I'm going to share the slide with all of us. Is a working tool that you can use in your day-to-day dispensing in your clinic. Now, before you be able to understand ophthalmic lens dispensing, it's not just about knowing the lenses that are out there or how to order them. There are prerequisites for this course. So if you have a very good foundational knowledge about these prerequisites, you are going to flow with the lecture. So the prerequisites include knowing how to take a detailed case history. Because once you start taking a case history in your clinic with what the patient is telling you, the required classes, it will start ringing in the knowledge of ophthalmic lens dispensing. So we commence by talking about the progressive addition lenses. So POW vary gradually in front of surface curvature from the minimum value in the upper portion to the maximum value, as we can see in this picture right here. So please, you are going to permit me, I'm going to be jumping a lot of things here because the slide is very long. So I'm going to, be jumping the things that are not all that necessary. So all these ones, you can read them up. I will do the explanation later. So because I know that most of us already know what a progressive addition lens means. So what you can see right here is a lens clock. You can see my arrow. This is a lens clock. So a lens clock is used to measure the base curve of a lens. So if you place a lens clock over this front curve of a progressive lens, you notice that the powers are different, and you can use the progressive lens to, a lens clock to read off the power of a progressive lens. And what will that tell you? It will tell you that the current progressive lenses we have, the powers are being adjusted by just adjusting the base curve. Unlike before, when you want to produce progressive lenses, the powers graduate by changing the thickness, and that is not aesthetically appealing. But now the thickness will remain the same while the base curve is what altered. So from here, you can see that we have 6 diopters here. Here we have 7 diopters, and here we have 8 diopters as you move down. That is the current design of progressive lenses. And that's why you are having the smooth curvature in front of your progressive lenses. So let's look at the progressive blank. You can see there are a lot of markings on the progressive lens, and these markings are divided into the temporary markings and the permanent markings. The temporary markings you can see there are the ones that are marked with yellow, and the permanent markings are the ones that are marked with laser, and they are written in white. So right here, we have the distance reference circle, we have the fitting cross, then we have the prism reference circle and the other one. So here we have the near reference circle. So you can notice that the permanent markings on the temporal side, we have the micro etchings. These 2 dots, permanent dots, are very, very important. And we're going to be talking about them later in the slide. All progressive lenses have on the temporal side, written on them, the add power. And then on the nasal side is written on them the logo and the material. So one might ask, why is it that only the add power is being written on the progressive lens and not the distance power? Because the add power plays a role in the kind of corridor length you want to order for a patient. It also plays a role in the kind of progressive lens design. It also plays a role on how the lab spaced or distributed the add power within the corridor length. And what is a corridor length? A corridor length is the distance from this fitting cross to the near reference circle. So that is the corridor length. So as we have at 2 here, let's say this prescription is +1 addition 2. It means that the prescription is going to graduate from +1, 125, down to +3 here, because the effective near power in this near reference circle is going to be +3. So this is the design of a progressive lens. If you look inwardly in this power blank, you can see that this demarcation here. This is where we have the peripheral aberration in progressive lenses. And the distance between these two peripheral aberration is known as the corridor width. And this corridor width can increase by just reducing this peripheral aberration. And this also is being determined by the amount of arc power. The more the arc power in a progressive lens, the higher the peripheral aberration will be. So this corridor width in most companies is what determines how the lenses are being designed. For example, if you are talking about Essilor, you notice that Essilor has what we call Varilux lenses, and Varilux have different designs. So what I'm trying to say is that it is the same with other companies, and those designs are based more especially on the length on the on the width of the corridor. Because the wider the corridor width, the wider the field of view for that patient. So in other words, if you are trying to order a lens for a patient that has a higher arc power, you will consider a lens design that has a wider corridor width. So for example, let's say if Dr. Love's prescription was +2 sphere with an addition of 1.5, the power distribution will graduate in this manner. That is how it will graduate on a progressive lens. So there we have these distinct zones, the distant, intermediate, and near. So in this seminar, the content of this seminar includes: 1, understanding your patient, analyzing the prescription the patient came in with, or the refraction you did. Then once you are done with that, how do you choose a frame or select a frame for your patient, because it is part of ophthalmic lens dispensing. From there, we go to talking about taking measurements after the patient must have selected a frame. We'll talk about mounting the lenses. So in between taking measurement, you must have ordered the lens and the lens has arrived. Now you want to talk about mounting the lenses. You talk about final fitting of the lenses. Then let's say the patient left the clinic, and after some time, the patient came back after 2 or 3 days or 1 week with adaptation issues. How do you solve these adaptation issues? Then if we have some time in this seminar, we'll talk about anisometropia, aniseconia, and isoconic lenses. Then if you don't have time, I will skip that number 8 and go straight to added values, where we'll be talking about all the features of a lens, of an ophthalmic lens, where we'll be talking about the treatment, the photochromic transition, the coatings, and every other thing you need to know about lenses. So we'll start with the first one, understanding your patient. This is the first step. This first step is essential to the success of a lens fitting, because if you don't understand your patient, you are not going to do any good job. And I must tell you that whatever you know in ophthalmic lens dispensing, the most important thing is to make sure that your patient is being satisfied. And you have to, the satisfaction starts from understanding that patient in all totality, understanding the concept of the patient's eye, the her preferences, the kind of frame they want, how the kind of job they are doing, knowing the kind of the lens in the market that will fit this patient. Everything is embodied into understanding your patient. So try to understand your patient's current glasses. What type of lens is your patient wearing? You have to find out if it's a single vision, bifocal, or progressive lenses. That same lens, what material are they using at the moment? The color and the coatings of that glasses they came into your clinic with. Then you go ahead to analyze the parameters. You do your lensometry, you see, is a prerequisite. Measure the sphere, cylinder, and all those stuffs, prismatic correction, if any. Then you find out when was that previous lenses dispensed. It will help you to know what could be the problem, because we are talking about ophthalmic lens dispensing. If a patient is to come into your clinic and is complaining, I'm having blurry vision, or I'm feeling dizzy, or any of those symptoms, you have to find out if this could be an issue of change in prescription, or maybe the lenses were not properly fitted, or so you need the date of the previous prescription to know if that patient is actually due for a change before you start going into analyzing other details. So you need to find out the visual performance with former lenses, measure and all those stuffs. You already know all these ones. Then understand the reasons for any lens change and confirm its needs. Then inquire of your patient's visual needs. What are the spectacles used for? Like, what does the patient want to get the glasses for? Is it for permanent or occasional wear? At what particular working distance for those of us who will be dispensing occupational lenses? You find out the specific requirements. Is it for profession? The person could be a lecturer. The person could be playing golf, or for any other leisure. Then find out the clarity of vision necessary and the field of view that is needed. He could be an architect who works on a very large board that requires a wider field of view. So asking this pertinent question will put in your mind an understanding of the lenses out there in the market. As you are asking the questions, your mind will be telling you, oh, this is where I should be going whenever I want to dispense lenses for this patient. So that is why a good case history is necessary. That is number one. Then we'll go into number two, analyzing the prescription. This is an overview of refraction techniques. Let's say you've done your refraction, your new refraction. So you have to compare the new correction with the previous one. If the difference is equal to or more than, let's say if the difference is 0.75 on the sphere and all these parameters, these are the things that you're going to do. So you have to compare the value of the addition with the ones suggested in this table here. So all these things you need to do once you are done with your refraction. You have to compare it with the previous prescription, especially when there is a 0.75 or greater difference on the sphere. You have to cross-check it. If you have a change of more than 0.50 on the cylinder, you cross-check it. If the ASICs is changing by more than 10 degrees, you have to cross-check it again. So that is why knowing the patient's previous prescription is very, very important. And especially if the patient has been comfortable in that previous prescription. So you need to be careful with your new refraction and what you're about to dispense. So these typical values that I've just mentioned above, the 0.75, 0. All those things, you can only exceed it in cases of real necessity. That's why you need to analyze and find out if this patient is having a difference of 1.25. Especially, you can see that in myopes. What could have been the the problem? Why is this power changing between this and this? For example, a patient who is wearing minus 250, and all of a sudden the patient came 6 months later, and the person is telling you that, doctor, my glasses are now blurry, and you want to confirm what could have been the problem. Carrying out a new refraction, and you are finding out that the minus 250 has changed to -4 within 6 months. It will suggest to you that this patient's myopia is progressing, and immediately it will, give you the heads up that this patient needs to be on myopia control lenses. So you see how these things will guide you into knowing the necessary ophthalmic lenses to dispense for your patients. So knowing that we have myopia control lenses out there is not enough, because I get to see optometrists who call me asking for myopia control lenses, and most of them will call and be asking me, doctor, I have a patient like this, what should I do? I'll be like, if not that we are familiar, in other countries, people who deal on lenses are not optometrists. So you must be able to know how to manage myopia before you go ahead and order these lenses. So it looks somehow calling a lens dealer to be asking the person what an optometrist should be abreast of. So I'm going to jump all this area. When I send the slide, you can read it up. These areas are self-explanatory. So this is still talking about your refraction. So number 3, we'll talk about the frame selection. The correct choice of a frame is important for an overall comfort. Very, very important. In fact, if you miss it in the frame selection, you've missed it. And an optometrist, it is your duty to guide a patient into selecting the appropriate frame. It is only in Africa, or let me say in Nigeria, that most optometrists, because of our reduced knowledge about ophthalmic lens dispensing, we allow our patients to select any kind of frame they want. In fact, you see a lot of, if you come to our lab, you see a lot of clients bringing all manner of funny frames. And the only reason why you are accepting these frames is because the basic knowledge of ophthalmic lens dispensing is not there. And when I see those frames, I'll be like, this patient is not going to be comfortable with this frame. Because the kind of frame you are allowing your patient to pick must match the kind of ophthalmic lenses you want to dispense. Are you getting me? Just about 1 hour ago, a colleague of mine just sent me a frame that I should look at it, that a patient wants to order a lens on this. One of the right eye is minus 050 and the other eye is -5. And the frame is like a sunglass that is curved. Now, -5 is going to be thick. So immediately I told the client that, please, before you order this lens, you need to send down the frame for me to measure the base curve of the demo lens inside it. Because if you don't order the lens in that same base curve, because this frame is not an optical frame, you might fit in the lens and the lens will start popping out because it's not taking the curvature of the demo that is there. So why did I ask the patient and my colleague to send down the frame? Because I already know that this is not an optical frame. So let's say this patient came to my clinic. I wouldn't allow that patient to choose that frame knowing his power. frame selection is very, very necessary. And most of us that are buying frames, you notice that most of our frames, they are tilted because of the way they are being packed. And any clinic that doesn't have a frame warmer is as if that the clinic doesn't know what they are doing in terms of ophthalmic, because it's a basic tool. You must have a frame warmer. Because before you even go ahead and fit a progressive lens, you need to make sure that the frame is properly adjusted before you take the markings on it. So there are a lot of things we need to say about frames, talking about pantoscope. So it's a whole lecture on its own, trying to learn everything about frames. You talk about the rimless, you talk about the screws, the kind of power that is built to be mounted, everything is in there. So ophthalmic lens dispensing is very, very big. So I'm going to stop it here for frame selection. So on a frame, we have what we call the frame parameters. You can see the markings. So most of us see these markings on the frame and we don't know what they stand for. So the first one stands for the lens width, which is the distance, the widest horizontal length of the demo lens, not the frame, the demo lens. So the middle number, which is 17, is not the bridge size. This diagram is wrong. The middle number is the distance between lenses. We call it DPL. That is where this demo lens ends to where this one ends, not the bridge size. Bridge size is different from distance between lenses. So the one we use clinically is distance between lenses. Then we have the tempo, and then we have the lens height. Sometimes, most frames, you won't see the lens height. So you need to use your meter rule or PD rule to measure it yourself. Sometimes you even see some letters beside it, like C25 or D15. Those letters or code is talking about the color of this frame. So whenever you want to order a frame online from a company, you have to quote the brand and these numbers, and they will get you the particular size that you want. So in terms of frame selection, there are a lot of things we need to know. The nose pad and the nose bridge, they all influence the progressive lens. So when you are trying to select a frame, please note this, that frames with nose pads can be adjusted when the fitting height isn't aligning with a patient's pupil. For example, you dispense progressive lens and the patient had left the clinic, and all of a sudden the patient is not feeling comfortable with the glasses, and the patient came back and you are trying to troubleshoot to find out what could be the problem, and you found out that the fitting height is either above or lower. So if that is above or lower, if that frame is having a nose part that is adjustable, you are lucky, because widening the nose part or bringing them together can either increase or decrease the fitting height, and you solve the patient's problem immediately. But if the patient is using all those kind of plastic frames that does not have nose pads, it means that you are going to reorder that lens, because there is nothing you can do about it. So you can see how frames can cost us a lot when we make mistakes in progressive addition lenses. So these are the kind of plastic frames that does not have a nose pad. So try to, as much as possible, to select a frame that the frame PD is very close enough to the patient's PD, because patient's PD is not the same as frame PD. So when you are trying to order a frame online, it is the patient's PD that you are going to use in order to order that frame. We talk about the wrap angle. The wrap angle must be good. That is the facial form. The pantoscopic tilt must be between 8 to 12 degrees. And when you mark the frame on the patient's face, it must be higher than the corridor length of the lens, of the progressive lens that you want to order. So you can see that the fitting height of this patient is the height of from the pupil to where the lens ends. Don't measure the frame. This thing you are seeing here is called the eye wire of every frame. Some eye wires are thicker than others. Metal frames normally have thin eye wires. So you don't measure the eye wire. What you measure is the length, the length between the pupil and where the demo lens ends. And this is known as the fitting height, or some people call it segment height. So your segment height determines the corridor length, that is the length of the fitting cross to the reading portion of the progressive lens that you are to order. So the corridor length must not be higher than your fitting height. If it is higher than your fitting height, your reading portion will be somewhere here and it will be cut off. So you see, once you know that a patient has a very high art power, for example, at 3, and you know that you need a longer corridor length in order to spread that big ad in that patient's glasses, it will not give you, the optometrist, a heads up that this patient with this high ad will benefit from a long corridor, so that there won't be image jump. Because if the frame is too small and the patient is using a high ad, you are going to order a short corridor, and the patient will start experiencing an image jump, the kind of image jump you experience in bifocals. So what do you do when you have such a high ad power? You encourage the patient to choose a bigger frame, especially the ones that their height is longer. In fact, the longer the height of a frame, the better it is for progressive lenses. So you can see this is a shorter fitting height. So pay attention to other frame details like grooving. It's informed on the suitable material and thickness. Grooving is very, very important. For example, this is a metal frame. This kind of metal frame now, most of them if you have to look at the beveling, most of them are not beveled. In fact, most of these metal frames behave like semi-rimless. You have to groove the inside. So any lens that you have to groove, any frame that you have to groove the lens on it, it means that you have to make sure that when you're ordering that lens, that the lens will have enough thickness. It is the onus lies on the optometrist to tell the lab what to do, because the lab does not have the frame. If you don't tell the lab will produce it with commercial parameters. You, the optometrist, is the person who has the frame, and you must provide all the information to the lab. So if you notice that this has a grooving inside, you will need to increase the thickness of that lens so that there will be space to groove the lens in this kind of frames, and also in semi-rimmed frames. So information is power, and it will help you to dispense the best possible lens or glasses for your patient. In fact, when you have a good knowledge of ophthalmic lens dispensing, you will not allow your patient to choose the wrong frame, because you want to get it done once. So there are some frames you shouldn't allow your patient to be choosing. For example, you can't allow your patient to be choosing this kind of shape, because you know that the reading portion are always on the nasal side because of convergence in near triad. So if you choose this kind of frames, the reading portion might be cut off. So having a knowledge of the design of a progressive lens will encourage you on the kind of frame that your patients should choose. So you can see these ones, the depth of this one, the depth of this one. Now, if the frame is having is too wide, it might encourage the aberration on the progressive lens to be more pronounced. So what are the quality control before a frame is being marked? This is where most of us get it wrong, and our patients will not feel comfortable with our progressive lenses. Once you have selected the frame, you have to confirm the comfort and the fit on the patient's face to make sure it is the size, it is sitting properly well, and the pupil of the patient is at least slightly above the middle of the frame. You check for 4-point touch. That is, make sure that one temple of the frame is not hanging. Everywhere is perfectly balanced on a flat surface. If it is not so, let your optician warm the frame and realign it for frames that might be having Xing. I'm going to show you what I mean by Xing. So this is what I mean by Xing. You can see some frames that are misaligned like this. So you need to hit them at appropriate junctions in order to what? Realign the frame. Look at the nose bridge. So most of these things, we don't pay attention to them. So if you don't pay attention, imagine you marking a frame like this. You mark a patient's pupil here, you mark it here. So it means that this one would be a bit higher and this one will be a bit what? Lower. So you have to pay attention to all these things. So after selection, adjustments can be made on the frame. Adjust the frame to fit the patient's face of the client so that the vertex distance falls between. So in progressive lens, the rule of thumb is the closer the frame is to the patient's eye, the better the experience. That is, the shorter the vertex distance, the better the experience. You know that only vertex distance can make a clinic reorder a lens. Just because you don't know what vertex. It has happened severally. I've encountered this case severally. For example, a patient's prescription was +3 with addition 2, a hyperope of that magnitude. And the patient fitted a rimless. The rimless was the temple of the rimless was very tiny. And that +3 lens with addition of +2 was heavy for that rimless. What happened? The weight of the lens was now sliding the frame down. And as it was sliding the frame down, the patient's vision became blurry because the vertex distance has increased. And again, as it has increased, as the frame has sliding down the nose, the pupil is no longer aligning with the fitting cross of that progressive lens. So everything became wobbling and blurry for the patient. So the patient called the clinic and said, please, doc, I'm no longer comfortable. These glasses is not correct. I'm not okay with the glasses. So when the patient came back to the clinic, the doctor did not know what to do. The doctor tried and did the refraction again, and it was still +3 addition 2. And the doctor became confused. And they wanted to reorder the glasses. I had to call the doctor and say, don't reorder the glasses. What you need to do, just call back the patient. Let me attend to the patient. I went to that clinic, only found out that the frame is just sliding down the patient's nose. I only asked the patient the question, does your frame slide down? The patient said yes, because the frame is a metal frame and it slips whenever the patient sweats. What was the solution? And I only brought out the frame and bent the temple for it to be very, very curvy so that it will wrap at the back of the patient's ear. And once it is wrapped, the frame will no longer be sliding down. And that solved the problem. And the patient became happy. They checked up on the patient 1 month later. There was no issue. The patient said, I'm enjoying my glasses now. So imagine just not knowing or being able to identify that this problem was emanating. This problem was emanating from the fact that the vertex distance was compromised. It would have cost the patient, the doctor, to pay another money. And once they order that lens, they will face the same problem again and again You see some clinics reordering the same lens over 2 or 3 times until the patient will get fed up and leave the clinic. So this is the pantoscopic tilt. It should be between 8 degrees to 12 degrees. So proceed with adjustments as necessary. Please, you have to have explained most of these places. Now we'll talk about number 4, taking measurements. Now you are done with the frame. You've gotten the perfect frame. So it's time to take the measurement. And this is the area where most of us also get it wrong. This is a crucial step for the success of lens fitting. You measure and then you check. During marking, patients should be seated in their natural posture, looking straight ahead. How do you know that a patient is looking straight ahead? How are we know that a patient is looking straight ahead and their neck is either bending to the left or to the right? I will use the 2 eyes to know. Once I look at the 2 eyes of the patient, if one eye is higher than the other, I will know that the patient's head is tilting. Because the patient's head might seem to you to be straight, whereas it might not be straight when you look at the 2 eyes. So use the 2 eyes to judge how erect the patient's head is. And if it is not erect, kindly take permission and readjust it. It is very, very necessary. Clinicians should position to maintain same eye level with the patient. Very, very important. You shouldn't be higher, taller, or shorter than the patient, so that you won't induce error due to polaris when trying to dot the lens. So you have to stay at 1 meter from the patient. So I'm just going to explain it. So once you are 1 meter away from the patient, you use your right hand to measure, to mark the left eye of the patient, and use your left hand to mark the right eye of the patient. Now, how do you do it? Most of us, what do? We ask the patient to look at the center of our forehead. That is wrong. When you ask the patient to look at the center of your forehead only, while you mark the 2 eyes, what you are marking is near pupillary distance. And what is needed in fitting of progressive lens is for you to mark the distance PD, not the near PD. So how do you mark the distance PD? You will mark it by asking the patient to look at far away. But that will not be possible when you are standing in front of the patient, because you are going to block the patient's view. What is now the alternative? The alternative is to mark it at near while the patient is changing gaze. How do we do this? We do it by asking the patient, look at my right eye. Once the patient is looking at your right eye, that is near. You mark the patient's left eye. You now tell the patient, please don't shift your head. Now look at my left eye before you go ahead and mark the patient's right eye. So that patient switch of their eyes from your right eye to the left eye, that movement is approximately 4 mm. And that is the amount you need to add on top of a near PD in order to make it a distance PD. So you don't need to ask the patient to look at the middle of your forehead while you are marking the 2 eyes. No. Ask the patient to look at your right eye. You mark the left eye of the patient. Ask the patient to look at your own left eye now. You mark their own what? Right eye. So I've already explained all these things. When you get the slide, you see the pictorial representation, and it's very self-explanatory. So these are other methods of marking the PD with a PD pupillometer. I'm going to jump this one. So this is another technical way of measuring it. You can measure a patient's PD with a pupillometer and then use a pie chart to mark the PD accurately. This one is very, very technical. So it needs a hands-on before you'll be able to know how to do that. So you can use what we call the fitting height apparatus. So once you've used the PD, pupillometer to measure the PD, and use this fitting height to measure this fitting height instrument to measure the fitting height of the patient to where the frame is stopping. You can see where the frame is stopping. Once you have the PD and the fitting height being measured, you now proceed to using this pie chart to mark the PD and then the fitting height. So the point where the PD and the fitting height means is the position of the pupil. So this instrument here, we call it a dye test instrument, whereas this card is either called a progressive lens chart or a dye test card. So the dye test instrument keeps the frame firm on the card. So it's already self-explanatory. So whenever you are marking the PD and the fitting height, the PD, the monocular PD of the right eye is allowed to be a little bit different from the left eye. But the fitting height is not allowed to be different. Make sure that the fitting height is the same, because there shouldn't be any vertical difference. If there is a vertical difference, there's going to be, you are going to induce vertical phoria in that patient. And you know, we don't tolerate vertical phoria. So you have to be careful with fitting height. PD has to do with horizontal phoria. So any small difference in the monocular PD can be compensated for. You see, I'm not talking about binocular vision. So a very good knowledge of, I've given us all these prerequisites, is necessary for ophthalmic lens dispensing. So additional information you need to know why using that dye test card. The dye test card will tell you the diameter of the lens to order. So after you must have done that, you place the mark, the pupil point on the dye test card or the progressive pie chart. You place it on the card. Once you place it, you'll be able to trace out if all the parameters of the progressive lens is being incorporated within the frame. So I'm going to show you the picture. So this is where the fitting height should be, the pupil point should be. So once you've marked a frame, you place that point on here. Once you place the point there, you can see it now. Now with this, I can be able to tell that the distance reference circle is accommodated, is not being cut off. I can be able to tell that in the near reference circle is not being cut off. I can be able to tell that all other parameters are accommodated with this lens, because you might mark a frame and you notice that once you put it, the near reading portion, it will be cut off when the lens arrives, and it is already a big mistake. And again, this chart will tell me the diameter necessary to order. Let's say you want your lens to be a bit thin. The smaller the diameter, the thinner the lens. So I know that this biggest diameter, which is 85 mm, is wide enough to cover the whole of this lens. But if you order this, it's going to make your lens thick. For those of us who are concerned about thickness, let's say your patient's prescription is around 3-4. You want to do everything possible to reduce the thickness. You order the smallest diameter that is able to cover this lens. You can see that this yellow line, the smallest diameter, which is 65 mm, was able to cover the demo lens. So you order it if you are concerned about diameter. But if your prescription is like plus 0.25 or plus 0.50, no matter the diameter, it's not going to be thick. So you can go ahead to order the biggest diameter to be on the safest side. So this is the smallest diameter that was able to cover the lens. I mean, the demo of the frame. This is another diameter. So see another scenario whereby after marking the frame, you notice that the reading portion is being cut off. What do you do in this situation? You have to ask the patient to choose another frame. But if this was the frame the patient brought and the patient is insisting that you should use my frame, what do? You are going to order a short corridor lens. That is, the distance between here and here is the corridor length. So you have to order a short corridor so that the reading portion will be inside the frame. And if this patient has a big diameter, a large a large add power, like at 250 or 3, and even if let's say the distance prescription is also high, especially in hyperopes, please reject this frame. When you are ordering a lens for a hyperope, moderate to severe hyperope with an add, the aberration in their progressive lens is very, very big. So resist the urge of using a small frame with a short fitting height. Let the fitting height be as long as possible. So reject this. This is a short frame side. Or if you want to go for it, you go for short corridor. So this is good. So this is what we call the corridor. This is how you know the corridor of this frame, of this lens. So this is a short corridor as it is written. So it is from 0, matching with the fitting height, to 14, where the near reference circle is. So that is 0 to 14. That is the corridor length. So if you are choosing any frame for this patient, the frame should have a fitting height of at least 16 mm to be able to be bigger than this 14 mm. Now, this is another one. You can see that the corridor length here is different. It's now 18 mm. And there is no short written here. It means that this is a long corridor. Now, staying on the frame, the boxing system, I'm going to just explain the boxing system. So this is known as the A, or the hedge boss. That is, the hedge boss means horizontal length of the boxing system. So for example, in this one, it is 43 mm. And the V box means the vertical length. In this situation, it is 37 mm. So the horizontal size of frames are normally larger than the vertical. So you can see the DBL, distance between the lenses. I did not call it nose bridge or bridge size. It is called distance between lenses. So the bridge side is from here to here. But the distance between the demo lenses is from where the demo lens ends to where the other demo lens ends. That is what we call the distance between lenses, and this is what we need. So when you divide this frame into 2 equal parts vertically, you have what we call the datum's line, and the datum's line crosses where half of the V box. So when you cross the PD, the frame PD of this frame, you get where the that frame PD bisects the datum line. You have what we call the geometric center of this frame. So this is the frame PD. And if you want to know a frame PD, what do? You add the horizontal, the hedge boss to the DBL. That will give you this size. Because from here to here, and you add the DBL here, if you shift 2 of them, it will give you is equal to this, the frame PD of this frame. So you don't need to measure a frame PD. All you need to do is to add the first 2 numbers. on that frame. If you are fitting a bifocal, this is the segment drop. And the segment drop is how the bifocal, the near ad, is dropping from the datum's line. And this one is the segment height. This is what we now call segment height. The initial one is segment drop. Now, these two black points is where the pupil is. So this is what you need to know. Whenever you are selecting a frame for a patient, you will use your mind's eye to make sure that as the patient is testing the frame, you are looking at their pupil to make sure that it is a little bit above the center of the frame. That is a little bit above the datum's line. If the patient's PD or pupil is on top of the datum's line or below it, it will never be okay for a progressive lens. It can be okay for a single vision lens, but it will never be okay for a progressive lens or for a myopia control lens or for an occupational lens. It will never be okay for it. So I see a lot of clinics bringing frames to us, and you see where the point, the mark is. It is even below half of the frame. I'll be like, if the patient's pupil is here, where will now the reading portion be? So frame selection is very, very important. And this is the reason why you will have, after dispensing your progressive lens, if your patient is wearing your glasses and they are trying to use their computer, you see your patient doing like this. I don't know if you can see my face. They are looking at their laptop like this. That is not a good progressive lens. It is an issue of the frame. So I've already explained all these things. So we'll move forward. Number 5 is mounting the lens. Now, after you must have selected the frame, you've already known the prescription, you've already known the base curve, the thickness, the diameter that you want. You've already known all these things. You now send them to your preferred lab. It could be any lab. And they have ordered what you want. So remember that the power of a lens is not the only thing you order. It's not the only information. You just send +1 addition 2. And you say, I need photo AR. That is a vague information. You need to provide information about the demo lens, the frame. The demo lens you see on a frame is not for fancy. It's not to cover that space. It tells you information about the appropriate lens that should be fitted on that particular frame. The demo lens tells you the base curve of the lens that you have to order. It tells you the appropriate thickness. You see some rimless, especially the Cartier rimless, they are a bit thick than other rimless. The demo on that Cartier tells you the appropriate thickness that will aesthetically be fine for that Cartier. You see some rimless, the screw is very long. It's not a mistake. Those long screws are for people who prefer rimless, that their prescription is very high. I once fitted a rimless for a -6 patient. If you use all those rimless that comes in pin, it will not be possible because they cannot carry the weight of that lens. Even if you use screw, if you use the rimless that their screw is short, it will not be able to penetrate the thickness of -6. So there are some certain things you need to pay attention. If not, you keep on recalling your patient and it will show that you are incompetent. So this is a very very good module that every optometrist should be abreast with. Now, let's say that the lenses have arrived, you are about to mount it, and the lab that you ordered the lens from has brought the lens for you. It is wrong for a lab to bring a lens for you and you collect it and the lab leaves and you went ahead and fitted the glasses, and later the patient came back and is telling you that I'm not comfortable with these glasses. And you started by checking the power in the lens and you found out that the power was not correct. It is wrong. The mistake is, even though the lab did the mistake, the optometrist has already glazed that lens and you have to pay for it. Because once a lab brings any lens that you order, the first thing you do is to do quality control. What are the quality control? You confirm the power in the lens, make sure that the lens is not scratched, make sure that every parameter, the diameter the lens came in is the same diameter you ordered for. Use your thickness gauge to make sure that the thickness you ordered for is the thickness that the lab produced it. Confirm every detail. Make sure that there is no warping on the lens, there is no tension on the lens, that the clarity of that lens is okay before you can confirm that the lens that was supplied to you is okay, before you go ahead and mount. Now, points to keep in mind. If you can, rule a Datum's line on the demo of your frame before sending out that frame to your optician. Particular attention must be paid to certain frame design, especially round and extreme cat-eyed frames. Now, let's take a look at this frame. What do you notice? Some opticians, when you send this frame to them, they will go and draw this line. This line to you might look straight, but it's not straight. It means that if they are going to fit this lens, that progressive lens is going to tilt. It means that if, as this thing is tilting towards, is looking like as if it's tilting clockwise, it means that your reading portion, instead of being here, will not be here. It will tilt, and the patient will not be comfortable. If this prescription has axis cylinder, as the optician is tilting the lens, the axis will also what? Tilt. Double wahala to already progressive lens that the patient is struggling to adapt. If you are okay, please rule your line yourself. It should not follow the design of the cat eye. No, it should follow the position of the eyes. This is how to rule a line. It must be very, very, very straight when you put it on a very flat surface. Now, frames that are circular like this, you must pay attention to them because it is very, very difficult to fit circular frames, especially when they have axis, and also especially when you are fitting a progressive lens. If it's just a single vision sphere lens like -2, you can go ahead and pop it in anyhow. It will just pop in. But you see this circular frame, very, very difficult to fit. Optician can easily use the axis, especially when they are glazing it with manual ager. It will be very, very difficult. They might change the axis. And if in progressive lens, both the axis and the reading portion might be changed. So these are the problems with most of these frame shapes. You have to be very, very careful with them. So these are the things that can be changed. Single vision with cylinders, and careful attention needs to be paid on them. Bifocals and also the progressive addition lenses. So I've already talked about quality control, what you need to do when your lenses, so you can read them up. So after the lens has been fitted by your optician, once it comes back to you, you do another quality control. You have to reconfirm the power, especially the axis. Okay, the optician have fitted my lenses. Let me reconfirm the axis, that the axis did not change. Let me reconfirm with a power chart here that where the reading portion, the near portion is supposed to be, did not change. So most of the times, what I tell our optician, for people who know what they are doing, is that temporary marking that you see on progressive lenses, tell your optician after fitting it, they should not clean it. You will be the one to clean it. Because if they clean it, you will have to go through the stress of retracing those markers. That's if you know how to retrace them. But if they don't clean it, you'll be able to look at those markings on the lens and be able to tell if the lens is fitting appropriately, and also if the axis has changed, you will be able to see it on your lens. So number 6, the final fitting. This is the moment of truth. Let's see what you have done. You are about to dispense the glasses. So you see what I'm talking about? this thing, you should not be able to remove it. And once you don't remove it, have your patient wear it. Once they wear it, you should be able to check if this fitting cross is sitting directly on the pupil. You can see this line. It is perfect. It is straight here. If this line is tilting, it means that the axis, the optician has rotated this thing. And most opticians, what will they do? They will clean it for you so that you will not know that the lens has rotated. And most of us will go ahead to dispense it, and you will never find out where a patient's problem is coming from. So it is after you must have asked the patient to wear it, and you see that it is okay. So for example, now you can see that this frame has a nose bridge. Let's say that this cross is a bit high, somewhere here. What do? You widen this nose pad, and the frame will come down, and that cross will be on top of the pupil. This is what you do to adjust those things before you go ahead and dispense, because it says a lot about your practice if patients don't return their glasses to your clinic. So you can read all this one up, and then finally you dispense your glasses. So finally, you just give recommendations and assist them and answer them on how to adapt with their glasses, how to look through the distance portion, the near portion, and the other areas. So number 7, adaptation problems, understanding the experience, the understanding and the experience. Fitting heights and troubleshooting. I've already talked about most of these areas. Please, the adaptation problem, you can read it up. It's self-explanatory on this slide so that you can be able to cover other things. So I've been able to explain it very well here. The symptoms that a patient can complain to you. If a patient says they need to lift their head or glasses in order to read properly, it means that the fitting height is just self-explanatory. You can go through them when you get the slide. So anisometropia, I don't know if we should talk about this topic because we still have more things to talk about, but let me just quickly rush through it. So you can see there, you have a power of plus 0.75 and minus 6. This is what anisometropia looks like. So in it, we'll talk about isoconic anisoconia and isoconic lenses. So anisometropia is unequal refractive power between both eyes. So we have categories of anisometropia. We have the mild, which is when the difference between both eyes is lesser than 1.5 diopters. It is often as asymptomatic. Moderate anisometropia is between 1.50 to 3.75 diopters of difference between both eyes. So this kind of difference can pose with, eye strain. It can bring about a mild difference in the image size, can even bring about reduced stereo acuity. So this moderate anisometropia depends on the patient. It might not, the symptoms might not be manifest in most patients. So we have significant anisometropia, which is when the difference is greater than 4 diopters. So significant anisometropia is a type of situation that can lead to amblyopia. So we call it anisometropic amblyopia. So this, when you have the difference between the powers of the eye, two eyes, if the difference is greater than 4 diopters, it will give rise to significant change and difference in the size of the image on the retina. And it will also bring about blurry vision, much blurry vision on the poorer eye. And the brain will be forced to suppress the vision on that poorer eye. And once the brain suppresses the vision in that poorer eye, it will lead to anisometropic amblyopia. And this occurs mainly in children. And this child is going to have a bad depth perception. And automatically it will lead to reduced binocular summation. So you can see how ophthalmic lens dispensing can help you solve a lot of problems, even people who are dealing with binocular vision, you need it. Even in low vision, you need this knowledge. Also note that in astigmatism, a difference of more than 1.5 diopters of cylinder is also considered significant. Is also considered a significant anisometropia. Now, let's talk about anisekonia. Anisometropia brings about differences in magnification and magnification. Because of these differences, each eye forms a slightly different sized image on the retina, which is known as anisoconia. Anisoconia makes it harder for the brain to fuse the two images into a single clear, comfortable picture. So when the two images are different in size, the brain cannot fuse it together because they are not the same. Therefore, it will lead to double vision and blur. So the brain abhors blur. The brain does not like double vision. So once that disturbs the blur and the double vision disturbs the brain, the brain will automatically switch off the one that is giving the worst image, and that is what we call suppression. So we can see this. Let's say a patient is having a plus 0.75 on the right eye and minus 6 on the left eye. The difference, the anisometropic difference here is a difference of 6.7 because one eye is on the positive side and the other eye is on the negative side. So the difference is 6.7. So when this patient wears a normal glass, let's say you just dispense anyhow single vision to this patient, and this patient is looking at somebody's face, this is how the images are going to perceive. Let's say this plus 7, 0.75 is giving a 6.6 vision, and the minus 6 is giving another 6.6 vision. This is how they are going to project on the macula. So this plus 0.75 will have a larger image that is clear than the minus 6. The minus 6 will have a much minified image on the macula. So when the brain tries to fuse both of them, it's not going to merge. You can see there will be a double vision of those two images. So what will happen is that it will now lead towards diplopia. So it occurs because of unequal spectacle magnification due to lens power, lens form, the thickness, and spectacle vertex distance. So everything about isoconic lens has to deal with magnification. So now, to go back, if you want to treat anisometropia, if you want to treat anisekonia with isoconic lenses, you can see the problem is the image size, that is the magnification. So the essence of isoconic lenses is to make sure that the magnification on both eyes are almost equal to the point that the brain can be able to fuse both of them without noticing any difference. That is the target of isoconic lenses to treat anisekonia. Magnification, please bear this in mind. Magnification, equalizing magnification. So I might want to ask this question: what is responsible for anisekonia in anisometropia? Does the large difference in refraction, a refractive error, or the spectacle used to correct it? Which one induces the anisokonia? Is this the refractive error or the kind of lenses that you're ordering for this patient in order to correct that refractive error? Which one induces the anisokonia? So spectacle corrections of anisometropia is the main cause of clinical significant anisokonia, because without any correction, if that patient is having plus 0.75 and minus 6 on both eyes, the main issue is not the brain is going to be having is not really difference in image size at that moment. The main issue is blurriness. There will be significant difference in blurry vision. But now, After you must have corrected the patient with a normal standard lens, the issue of blurriness will disappear. What the patient the brain will be battling with now is the unequal image size will not become significant because the images are now clear, but the images are different in size. So there will not be, the brain will not be battling with diplopia. So the anisoconia emanates mainly from the spectacle. So that is why we now bring in isoconic lenses to battle and combat this problem.
Sorry, excuse me, Dr. Hadi. It's just to remind you that we have barely 15 minutes to round up the presentation. Just a quick reminder. Thank you very much.
All right, thank you. So you can go through this. We have symptoms of anisometropia. We have all this. You can read it up. Then isoconic lenses is all about equalizing the shape. A lot to talk about here, and examples that we can talk about. There is a case study you can use to do that. So I would, if we had most time, I would have talked about how you can deal with ordering an isoconic lenses. Is a very interesting. We experience that every day. So the last part I'm going to talk about quickly, and I'm going to rush it. Once you get the slide, you can look into it, is added values. Why do I call it added values? I call them added values because we've already discussed the main thing. So remember that in this seminar, we only discussed progressive addition lenses. I didn't talk about single vision. I didn't talk about occupational lenses or any kind of design of lenses. The main thing in lenses is the material of the lens and the power in the lens. These are the main thing. Whenever I'm teaching this topic, I like using this analogy. It's just like somebody who went on the roadside to buy, to eat mama put. If you don't have money, the main thing you should be talking about is just rice and stew. And rice and stew is just like the lens itself. It is only when you have money you'll be telling the woman to put 2 meat, put spaghetti, put beans, put plantain, 5, put this. All those ones are known as added value. So on lenses, you can just dispense uncoated lens without any treatment, just give somebody -2. That is the main thing. So any other thing you are doing is either trying to enhance the clarity in the eye or to protect the eye. So all those things are known as added values. So added values aims at clarity, transparency, durability, aesthetic appearance, that is fashion, and also protection. So we dispense these added values either to improve clarity, how transparent the lens will look like, how durable for anti-scratch, anti-smudges, the aesthetic appearance, and also the protection. So talking about transparency and durability, these are the non-natural enemies of lenses: reflection, absorption. So anything you are going to dispense, like anti-reflective coatings, reduces the amount of reflection, makes the lens to a good amount of light to pass through the lens. So other encountered enemies you can have on lenses is enemies like scratch. They are not natural enemies. Those ones you can't encounter them. Deaths. So on lenses, you have coatings like anti-scratch in order to protect the lenses from that, and anti-smudges to protect it from dust and thereabouts. So we have what we call chromatism in lens materials. So the higher the refractive index of a lens, the greater the chromatism in that lens. And we use strong anti-reflectives to coat over high index lenses in order to reduce the amount of chromatism. So the higher the chromatism in a lens, the lesser the clarity of that lens. So CRO 39 with an index of 1.50 has a very good Abe value, which signifies the clarity of that lens. So you can go through these write-ups to know about chromatism. So what you need to know is that the higher the refractive index, that is if you change a lens material, refractive index is also known as lens material. The higher the refractive index of any lens material, the higher the chromatism will be, because they bend light more. Therefore, they will cause chromatism more. The lesser the refractive index, the higher the Abe value. Abe value talks about how clear the lens will be. So Abe value is inversely proportional to chromatism. So bear in mind that when you're ordering high index lenses, the Abe value, the clarity is reduced. Please, can you mute yourself? So these are lens coatings. You need to have a good information of what lens coatings does on a lens, so that you can be able to inform your patients and educate them and be able to convince them why they need it, so that they can be able to pay good money. Not having a very vague knowledge of the lenses. Some of us will have vague knowledge of what this lens coatings does and how they look like. So you can tell, I wish we had time, I will be able to explain all these things properly. I've added a lot of pictures in order to help us assimilate. So these are do's and don'ts that after you must have dispensed your lens to a patient, these are the things you must tell them not to do in order to make their lenses to last long. They shouldn't put it inside a car because heat can peel off coatings from it. And this is what they need to do in order to protect their lens. We talked about anti-reflective layers here. We have on the slide the good and bad of blue light. What you need, the coatings that you need to dispense in order to, if you are trying to dispense a blue coat to a patient, if you go through this slide, you'll be able to educate your patient very well with confidence what a blue coat lens means, what the things that they protect the eye from. Because most of us, we dispense blue light, but if they ask us what is the effect, what does blue light do, the only thing we can say is that it protects your eyes from computers. It stops at that. If you have only that information, you can't be able to use it to make good money from any client. So we should be able to go through this. We'll talk about anti-smudges, water and dust repellent layers on coatings. So after that, we'll talk about dispensing sunglasses. This is an untapped area in Nigeria here. We hardly dispense sunglasses with prescriptions. You should be able to know how to dispense these glasses, the colors that are available, how to select the colors. In fact, as an optometrist, you should also be a fashionista. If you are not a fashionista and you don't have a knowledge of ophthalmic lens dispensing, you are underutilizing your certificate. These are everything you need to know. Sunglasses is divided into three. We have tints, we have mirrors, and we have Polaroids. So I've talked about tints here, I've talked about Polaroids here, and I've talked about mirror lenses. You can read them up and you know all that they are talking about. So finally, this is how to order a lens. Indicators, you can choose a material. These are the things that can make you to choose a high index material. When you're considering about the thinness, the impact resistance, you know when to order which material. How do you choose a lens coating? What are the indicators that can make you choose a good lens coating? The power. If you choose a coating that can offer transparency, because anybody who has a high power is already struggling with vision. Knowing a lens coating that has a very good AR will be able to allow good light to pass through the lens, because the thickness of that power is already diminishing the amount and the quality of rays of light entering the eye, and it will reduce the quality of the image entering the eye. So aesthetics eye protection, all these things you have to understand your patient from case history in order to know the kind of lens coating you are going to order for them. Occupation, bankers will tell you the occupation can influence the kind of coating you want to order for them, the kind of glasses you need to order for them, a lot of things. So light management indicators means the properties or the treatments on a lens are used to manage the amount of light entering the eye. It could be photochromics or it could be sunglasses. Photochromics changes in between indoors and outdoors, but sunglasses does not change. You have to choose one for the patient. And these are what they... So here, these are the options for light management: photochromics, tints, mirrors, Polaroids, all these things manage the amount of light entering the eye. So in our next section of this webinar, these are other areas of ophthalmic lens dispensing that we have not even talked about. You need to go and learn them and go deeper into them. You talk about frames. When you're talking about frames, learn about facial asymmetries. Learn about different frame materials, acetates, metals, how they are being grooved, the pantoscopic and retroscopic tails, wrap angles, boxing system. Learn everything about it. Then learn about effects of spectacle lens parameters. That is refractive index. That's what we should have talked on under anisoconia, and that is isoconic lenses, but we weren't able to discuss that in details. You learn about prisms and decentrations, how you can do that on ophthalmic lens dispensing. We talked about this one briefly. You learn about occupational lenses, office lenses, freeform lenses, digressive lenses. You learn about myopia control lenses. We have brands like Myopilus, Myosmart, Stellar lenses. For those of us who are in UK and other parts of the world, you should be able to know all these things. Other designs in progressive addition lenses, soft and hard designs. You should also know about low vision aid dispensing. It is part of ophthalmic lens dispensing. In conclusion, I enjoin you as an optometrist to incorporate the art of optical dispensing into your practical practice to enhance your clinical practice and professionalism. In all, improve customer satisfaction. Please use these fitting guides regularly. Good luck and happy patient satisfaction. Thank you.
Yeah, thank you very, very much, Dr. Hardy. Thank you for this wonderful and effective presentation. I can at least speak for myself. I'm very, very certain that my patients will be happy. At least the first patient I'm going to see tomorrow would have a very good outcome. But I'm going to definitely apply the tips I learned today while attending to my patient. So again, thank you very much, Dr. Hardy. I'm very grateful for this opportunity. And so we're going to take some questions. So if you have any question, you can drop your questions in the comment section. So please, you can drop your questions in the comment section so Dr. Hardy can help us address. Okay, so I have a question here, Dr. Hardy. So uh, Dr. Mez is asking, how do you calculate the base curve of a demo lens? How do you measure the base curve of a demo lens?
Okay, so how you measure it? In my room here, I have these tools handy. As an SLO staff, I carry it about trying to assist patient, but these two tools are basic tools that every optometrist must have in their clinic. I mentioned of the frame warmer. So this is a lens clock. That is what you use to calculate the base curve of a demo lens. And this is a lens thickness gauge. You use it to measure the thickness of your demo lens.
Dr. Hardy.
Pardon?
Your video is off. We can't see you. The instrument you are showing us, we can't see it.
Check the one that see, I'm using I'm using my laptop and another phone.
We can
Please
see
check
you
for
now.
Hadi Madrid. You'll be able to see my picture.
Okay, okay, yeah, I can see it now. Thank you.
Yeah, check for Hadi Madrid. You'll be able to see my picture. So now this is a lens clock. And when I bring out this lens clock, this is it. This is how it looks like. So when you remove this, you see the pins of the lens clock. So I have a frame just right here on my table. So you place it here. So once I place this over the surface, you can see the pin will move. It will read it off. So when you look at it, you can be able to see a plus and a minus on each side. So when the pin goes towards the plus side, for example, when the pin goes towards the plus side, you can see that it means that this is a convex lens, and it will tell you the power of the front curvature. This is what we call front vertex power of this demo lens. If I measure the back, this is the back vertex power. You can see it has gone to the negative. That is, the back of this demo is concave and the front is what? Convex. So if you look closely on this lens clock, it has 3 circles, 3 markers. So each marker depends on the index of the material that you are measuring. If you look at here, you will see where they wrote n equals to 1.50, n equals to 1.6, and n equals to 1.53. So you use the reading corresponding to the material that you want to order in order to know the base curve that you are to order. So imagine when I'm using all those police frames, if I measure the base curve, it's going to be more steep. That is more plus power. You can also use this to measure the power of a lens. If you want to know the power of this lens now, if I measure here, it will give me +6. If I measure here, the back, it will give me -6. +6 -6 means plano. But what it means that a +6 base curve, the curvature was used. You can also be wearing a plano of +4 front curve and -4 front curve. It's the same prescription, but the curvature is different. So this is what you use to measure the lens clock. That is, to measure the base curve. It is called a lens clock. It's very, very cheap.
Okay,
Thank you.
Yeah, thank you very much, Dr. Hadi, for the explanation. Dr. Ahmed, you raised your hand initially. Please, can you drop your question in the comment section? Thank you very much. Okay, so Dr. Hadi, I also have a question. So while we wait for other questions, I wanted to understand. I think you correct me if I'm wrong. I think you mentioned that the higher the index, the more the the more the chromaty or something like that, and of course the chromatism, unless the patient gets the clarity reduces or something like that. So I'm trying to say, in cases where the patient has a high refractive error, right, and we want to order a high index lens, so what exactly do we do to balance the clarity and then the thickness of the lens? How do we go about it? Because of course, I think it's advisable to order a higher index for this patient. So what are there necessary things I'm supposed to do to ensure that the patient also sees clearly with these high index lenses?
Okay, these are part of the things that I needed to explain where the area I was talking about coatings in the slide. Because you need to understand the features of every coating. With a strong anti-reflective coating, it's already eliminating the chromatism, and it's also improving the clarity. And if it's improving the clarity, it means it's increasing the Abe value of such a lens. For example, in Exilo, if you order for any high index lens, it comes with a factory fitting anti-reflective coating. They can't produce that kind of lens without any factory fitting, but you can request for a more fortified AR. Having a knowledge that anti-reflective coatings, high index lenses, they have higher chromatism and their clarity is being reduced. So you might request for a more fortified coating. For example, in Exilon, there is a coating we call Crystal Sapphire. It has 100% AR. Hardly will you be able to see any reflection on it. So such a lens means that the reflection on it is reduced, and also it combats chromatism. And again, in ophthalmic lens dispensing, when you know that you're ordering a high index lens of a high power, you should be able to make sure that the patient is choosing a smaller frame, because the wider the diameter, the greater the peripheral chromatism will be. Because the thicker the lens on the edges, you have more chromatic aberration in those areas. So you want to cut off those chromatic aberration by reducing the amount of the size of the frame. So you have to have a holistic knowledge about everything before you be able to reduce that patient's improve the Abe value on the product you want to order. I don't know if I've answered your question.
Yes. Thank you very much. So basically, it's just to kind of add a quality anti-reflective coating to reduce the effect of that lower Abe value.
Yes.
Okay. Thank you very much. Thank you. So do we have any other question? I'm yet to see any other question on the comment section. But while we wait for more questions, I also have another question to Dr. Hadi. So in the specifications that are visible on the lenses, I could see that there was one point where you kind of circled out the logo or something like that. So the logo, what logo does that signify? Is it the logo of the company or?
Yes. For example, all those things are very, very important, especially when a patient is, most people find it difficult to understand external lenses because of the big names. Preza this, Virus this. Even if you go to Zeiss, you will be seeing all those big names. All those things are just names. Are you getting me? If you have an understanding of ophthalmic lens dispensing, you can be able to understand those names. So, for example, now, you talked about the logo. A patient might walk into your clinic. The first thing I look when a patient is wearing a frame, I have to do an inspection of the kind of lens they are wearing. For example, now, this is an Essilor lens. Once this lens comes into my clinic, I will superimpose it over a light to check for that logo. The logo will tell me the kind of lens this patient is wearing and what I'm to do next. Let's say this is a first-time patient, and this patient is wearing an Essilor lens. If you don't, most of us are not aware. What they will do, they want to do to you will go and order a local lens for this patient. What are you doing? You are downgrading that patient. I'm not doing marketing. I'm just trying to tell you that you need to understand the kind of lenses that person is wearing. Even if that person is wearing an Essilor lens, you can still order another Essilor lens and you are still downgrading that patient. For example, let's talk about progressive lenses. Progressive lenses in Essilor, main Essilor is known as Virus. So there are different designs of Varilux, and we have the latest design, XR. Let's say somebody is wearing Varilux XR, which gives you the best experience. And you can't even identify from the logo that this is a Varilux XR. And after doing the new refraction, the patient tells you, oh, Dr. Larry, please, this is an Essilor lens. I want you to order this Essilor lens for me. The patient that is telling you that this is an Essilor lens does not know the design he's wearing. All he knows that it is an Essilor lens. And then you go and order Essilor lens, and you order the lower design of Varilux, let's say Varilux Liberty, the one that is cheap, because everybody wants cheap. And this patient will now wear that glasses. This is a patient having +3 addition 2. You can see that the patient will notice that effect because they know that they will not start telling you, I just don't know how to explain it, but my previous glasses is giving me a better experience. So what am I trying to say? The logo tries to tell you which lab are you dealing with. If this patient is wearing Zeiss, or this patient is wearing Rodenstock, and the patient says, please, doctor, I like this, my lens, and you are within the reach, you know how to order Rodenstock or Zeiss, please go ahead and order that product for that patient and order the same logo for that patient. If the patient says, okay, sorry, you can switch me from Rodenstock to Essilor, and you don't know, you can ask an Essilor staff, please, my patient was wearing this Rodenstock and this is the logo I saw on it. Please, can you give me an equivalent of this design in Essilor? So that is what the knowledge of that logo does for you. And most of you might not know, in Essilor, we have different logos, the same thing with other companies. So you have to ask their rep for their catalog. We have a catalog where we write all the logos. Whenever you see a logo, you know which lens is that. So as a doctor who is ordering from that company, you should be able to have their catalog to know when you see that logo, you'll be able to tell which lens your patient is wearing. Thank you.
Yeah, so thank you very much. I think I can understand that very well now. So please, does anyone have any other question? I'm trying to go through the comment section to see if anyone has dropped any other question. Okay, so I think we don't have any more questions. So I still want to use. Okay, so a question just came in now. So the doctor is trying to find out, in lens marking, is there any significant difference between how a patient sees while wearing lenses marked when he looks? Okay, so I think the person is trying to ask if there's a difference between when looking at, for example, I'm a doctor and I'm trying to take the marking for a progressive lens. So is there a difference when the patient is looking at my nose bridge as against where the patient is looking at my left and right eye, at my left or right eye, as you explained during the presentation? So is there any difference between the both of them?
Yes, there's a very huge difference, please. A progressive lens is a lens that it has already been designed. It's not like a single vision lens. It has already been designed. There are landmarks. So the pupil that you are marking is a landmark, is a reference point for other designs. Once you've missed the positioning of that pupil, it means that every other thing on that progressive lens, you've missed it. That's why that pupil is very, very important. And the way it is designed that you have to measure it at when the patient is looking at far, because the glasses they are wearing, they have to look at far. Are you getting me? Then the near portion is converging. And what we call that convergence in lenses, we call it inset. So if you are measuring the near, if you are asking the patient to look only at your forehead, it means you are only dispensing readers. No. You have to measure the far PD, just like when you are doing your refraction. and the divergence lever on your phoropter is at near, it's not going to be okay. You have to push the divergence lever far apart for it to be at part PD, for it to do a proper refraction. When you want to do the near add on the phoropter, you closing the divergence lever. So it is important that you ask the person to look at one eye before you mark that eye. Before you mark the other eye, ask the person to look on the other eye. That movement is 4 mm on top of the near PD, which will equate to distant PD. So it is very, very, very important. That small shift on the PD is very, very important. Please don't miss it. So it is necessary that you observe all these things, and in your practice, you can be able to boast that no patient returns your glasses. You can easily, for example, there is an airline, KLM. Since their inception, they have not experienced any plane crash, and that is why if you want to book the airline, their plane is always expensive because of that reputation. So in your practice, you can also have that reputation that at least in a year, the amount of patients that returns their progressive lenses have reduced drastically. Thank you.
So thank you very much. So just a follow-up to that particular question. So do you also consider the doctor and patient sitting position while taking this marking? Is it also a factor to consider?
Yes, I consider that very, very well. I consider that very, very well. For me, in my own practice, I prefer standing. Why do I prefer standing? When I stand, I can be able to adjust myself instead of the patient. I can either squat, reduce my height if I'm taller than the patient, or stand on my toes if the patient is a bit taller than me. But if you are very, very short, you can make use of adjustable stool. You have to fix your patient's stool and let your own be adjustable. The idea is that you should be able to be on the same height. Now, one might ask, why is it that I prefer standing? I prefer standing because standing makes it easier for me to easily adjust myself. When the patient is sitting and I want to mark, I notice that it's not aligning. I have to go through the rigorous process of telling the patient, please, ma'am, can you adjust your seat? Please, sir, can you do this? Can you do that? And you take again. It's not still matching. You start again. Please, ma'am, please adjust your seat very well. Blah, blah, blah. But if you are standing, the patient is already standing. You are the one just adjusting yourself. It's easier. Because there are kind of patients that will come into your clinic. You even be afraid to be telling them, please, ma'am, please, sir, adjust yourself. Imagine when a senator walks into your clinic. Those people that does not even say before you walk in as a young optometrist, they'll be asking you, are you the one attending to me? Here we enter into your body. Imagine when their head is not sitting well and the man is having big beer, and you want to touch the man's head and adjust the head. You know, sometimes it's a bit difficult for us. So that's why in this kind of marking, I prefer to stand. Standing allows me to look at you very, very well. It will also allow you to look at a straight ahead position in order for me to mark, dot that thing. And another reason why I prefer standing is that probably in the clinic, there is a particular spot in the clinic where there is a good lighting. Maybe you want the person to come and start close to the window where you'll be able to see the pupil very well. Or come and stand under the bulb where you'll be able to see the pupil very well. Because if you can't see the pupil very well, you cannot be able to mark. So that's why I prefer standing. Thank you.
Okay, so thank you very much. I think we have another question, and the doctor is trying to understand if when you take a mark, when you mark a lens and the optical center of that particular mark, it's below half of the dummy lens. What do you do in this particular situation? So you've taken a marking for that particular frame and it's below half of the dummy lens. Is there is there anything we are supposed to do in such a situation?
Now, if you pay attention, when I was talking about frames, the section where I was talking about frame, I said that I talked about it in frame selection. You don't need to, for you to know what you are doing, you don't need to wait for you to mark the lens, the demo frame and demo lens before you know that this frame is not okay. As an optometrist, when the patient is selecting a frame, once the patient wears it and the patient is looking through the mirror, you know, the patients will always be looking, doctor, is this one fine? Is this one, does it fit me? As you are, as the patient is asking you if this one is fine, me as the optometrist, it's not even the fineness of the frame that I'm looking at. I'm already gauging where your pupil is passing. So I already know from gauging the frame that is already above this middle of this thing. Your eye should be a bit above the middle of the frame before in straight ahead position before I will be able to tell you, answer your question whether it's fine or not. So that is where you should leave. That is where you should start from stopping the patient. Please, ma, you are going to fit a progressive lens, and this your prescription is complicated. Your cylinder is high, and your arc power is high. Please, you need to choose a very, very comfortable frame in order to have the experience. Remember that your old classes, you were complaining of this and complaining of. So please, you need to choose this particular frame in order for me to get this thing perfectly well. When you explain to the patient in layman's understanding the necessity or the reasons why they have to choose another frame, they will gladly, choose another frame. To answer your question, once you notice that the fitting point is below just tell the person to choose another one immediately. So that's why I'm going through all this process to explain to you. You don't even need to come and start marking it. As they are choosing it and as they are testing it on their eye, you should be able to know that this is not going to work already. Thank you.
Thank you very, very much, Dr. Hadi. I just also wanted to just ask for clarity purposes. I think you mentioned something about going close to a light source to kind of get to see a better view of the pupil. Is it also possible to use more like a pen torch or a torchlight to just shine by the side of the patient's face to be able to pick out the pupil while taking the marking? Is that also an alternative way of doing it?
Yeah, you can do that because some people, when they want to mark, their hand is very, very shaky. Now, this is what I want to tell you. When you want to mark, let your middle finger be on the patient's forehead, not on the frame. Because if you put it on the frame, it's going to shake like this. It has to be on the forehead, and you then mark. Are you getting me? Now, for some people, they find it difficult holding a torchlight while marking. Their hands will be shaking. But you can also hold the torchlight, and you have to be very, very observant how you point the torchlight, because if you don't point, my mic is not off. Who is saying my mic is off?
Sorry, we can
Dr.
hear
Lori,
you.
can you hear me?
I can hear you. Yes, I can hear you very well.
Okay, so for example, if I look at how I'm shining this torch on my eye, if you shine it like this, you are going to dazzle my pupil, and you will not be able to see it very well. But if you shine the light by the side to illuminate the pupil from the side, you'll be able to see it. And another reason why you need to use a torchlight, there are some patients that will go and buy sunglasses and want to fit their prescriptions on that sunglasses. So some glasses that the glasses is already darkened, you just need to use your torchlight in order to illuminate it. So for example, if I'm wearing this sunglass now, you will not be able to see my face. But if I point this torchlight from the side, you can be able to see my pupil and mark it. But if you do it like this, you won't be able to see my face. So using a torchlight is very important and is much, much allowed.
Thank you very much, Dr. Hadi, for that clarification. So I think that's all for all the questions asked for today. So thank you once more, Dr. Hadi, for the very educating and insightful presentation. And I also want to use this opportunity to thank everyone that had joined and asked questions and contributed in one way or another. And so this brings us to the end of this particular presentation. And subsequently, we are going to also have further presentations and probably maybe a part 2 of this particular presentation. So we encourage each and every one of us to just stay tuned, or just follow us on our various social media platforms, and where we'll definitely announce subsequent presentations. And so yeah, up until next time, I wish each and every one of us a wonderful night. And for those staying in Lagos, just try and sleep on time so you'll be able to beat the traffic tomorrow morning. So thank you everyone, and have a wonderful night. Yeah, bye.